have access to, and I've talked about this particular disc before, it's called, I always call it Physio Suite, but it's Interactive Suite or something along those lines. But it's got all the body systems in it. When you load it up, it will be on your left-hand side of the screen. And if you have one of the newer ones, they have the immune system on there. Hands down, probably one of the best ways of learning the immune system. Mainly because it's animated, there's a lot of humor. It's kind of set in the castle days because they talk about the different lines of defenses, and they just do a phenomenal job at it. So since we have such a small amount of time, I mean, the lectures are going to be the same as if you took it during a regular class term, but you don't have as much time to really kind of stick it in your noggin as you would if it was a full term that you would have during the regular school year. So I think I have a couple discs, so it's kind of a first come, first serve. So if you do not have access to one, you might want to email me, and we can find a way for you to pick it up. Because it's, like I said, it's something that I recommend having. So, immune. One of the key things I want you to take away from this process, this chapter, is the simplest term. Not like economics, supply and demand. This is the down and dirty of the immune system. Self, not self. Okay? Anything that the body does not recognize as self, it will attack. So everything in our body has some sort of a marker on it. Okay? And when we proceed through the lecture, it'll probably not show up until next week, but they're called major histocompatibility complexes, class 1 and class 2. Okay? They're basically, the easiest way to describe them, it's a flagpole. And on the flagpole, there is a flag. And what we're going to talk about today is so something on this flag is going to say one of those two things. If it says self, the immune cells are just going to wave, just keep going by. If it says not self, then whatever cell this is attached to will get destroyed. Now, as we go through what I'll start on Monday, is there is this, and obviously these aren't the things on there, they don't have little tiny plus signs, but it's different shapes that designate something more specific. Okay, this would represent a particular bad guy. And that's a term I use a lot as we go through here because I think it just drives the point home. Okay? So, the first system we're going to talk about is the innate system. And this is their criteria for activating the immune system, self, not self. This is going to be the adaptive system. In other words, it reads. So this just, it doesn't care who you are. Are you supposed to be here? Nope, dead. Whereas there are little policemen that run around that I could be in a room full of bad guys. All of you can be bad guys. But when I look at what I was given on my little spreadsheet during roll call this morning, it's like I'm looking for bad guy X. This is bad guy X. So I don't pay attention to you. All of you are bad guys. That's this stuff down here. And that's on the flag as well. That's kind of the down and dirty of it. Self, not self. Anything that's not supposed to be here, we will kill. Your body will kill. Now, this is one of these, remember I told you yesterday that the biggest problem with the immune system is it's this multi-act play. Okay? And it's hard to put the acts together and figure out what happened in Act 1 and how that relates to Act 3, Act 5, and Act 6. And hopefully, when you paid your ticket and you went into the theater, you got a little doohickey that says what's going on. This is your doohickey. This is going to tell you, this is one of these things that you should either reproduce or make a copy of. And as you study this, make sure you're able to put things where they go. because we're going to have 3 lines of defense. 3 things that the body's going to do to protect you from bad guys. Okay? The first one is we're going to protect you from something ever entering your body. So this box right here is the first line of defense. Don't let it in. This is the second line of defense. Oops, got in. Now how does the body handle the bad guy that got in? And the other term that I'll use is either antigen or pathogen. Okay? And I'm going to expand on antigen when we get a little bit farther into the lecture. Pathogen's a perfectly good term. They're just things that have the potential of causing disease. That's what a pathogen is. Okay? And then, this is what's a little confusing, this whole box. So these last 2 are the third line of defense. So when we mix them up, or not mix them up, but when we break them up, we have the innate is at the top. And I'm going to give you another name for it in just a second because you are responsible for a couple names for this because it's still used interchangeably. This is a system that you have essentially at birth. And when I say essentially, it takes about 6 months to a year to really get your immune system up. This is one of the reasons why breastfeeding is a very, very important process because it's a way of conveying mom's immunity to the baby until the baby's immune system kicks up into full swing. I will tell you though, just for those of you who might be moving in that direction, the healthcare thing, leave moms alone if they choose not to breastfeed. I've gone in there with babies and, you know, mom's just bawling. It's like, why are you crying? You know, this lady came in, I told her I wasn't going to breastfeed, and she essentially told me I'm the most horrible person in the world. They're called lactation consultants, and they were just nasty. If somebody doesn't want to breastfeed and you provide all the appropriate things of why they should, leave them alone. You don't have to be the little breastfeeding Nazi. I don't know where I was going with that. Come back to me in a minute. Oh, innate. So this system, again, is what you have. That's why it's called innate. The other term I want you to know for it is called the non-specific. Why is it non-specific? It doesn't care which bad guy you are. It only cares that you are not self. So again, to use the example, and I'll drop down to the adaptive system in just a second. The adaptive system is, again, if you're all bad guys, I personally only care about one of you because that's my job. If I was part of the non-specific system and you were all bad guys, I'd mount an attack against all of you. Why? Because you are not self. Does that make some sense? And then when we get to the adaptive system is referred to as the specific system. Again, why is it specific? Because it's specific to one particular bad guy. For every good guy, there is one bad guy in the specific system. Yes, sir?
You know what you mean by that is for every like T cell, it's only looking for one.
For every which type of cell?
For every any kind of like
B or T cell, right.
Yeah, they're only looking for one
Right.
certain kind of.
Right. So there's one cop for one bad guy in the adaptive system. In the innate system, there's a cop that can get multiple ones. But as we're going to go through here, you're going to see that there's a little bit better opportunity in that adaptive system. There are a little bit better cops. Why? I'm only looking out for one bad guy. I'm not looking out for all of the bad guys. Now we're going to spend our time talking about the innate system today. And that's probably where I'm going to stop regardless of the time, because that way it allows you to get one huge arm of the immune system under your belt for the weekend before you come back and we jump into the specific system. Okay? So again, our first line of defense, hey, let's keep it out of our body. Okay? So what we have skin, as long as you have intact skin, okay, that pretty much keeps everything out. Now we'll talk about, when we go into pathophysiology at the end of this chapter, we'll talk about some specifics. But if I was to take a pint of blood that had HIV in it, okay, and I just let it drip, and I'm not recommending this by any means, but I just let it drip over this part of my arm, okay, HIV will not penetrate the skin. Why? It's intact. Okay, it doesn't burrow through anything. Now, intact skin, if you have a scab, that's intact skin. So even if you cut yourself, pretty quickly the body sets itself up so that it's going to fill itself in. Okay? So if you ever watch pre-hospital specifically, you'll see this a lot. They love gloves, and because they don't really have as much, they don't know what they're getting into. Most of the time in the hospital, we kind of have an idea about what I might be seeing when I walk into a room. Pre-hospital doesn't. But if you ever watch pre-hospital, especially on a hot day like this, if they walk into a patient's house, they're going to have their short sleeve shirt on. And they're going to have gloves that will come up to here. Why aren't they wearing gloves all the way up? Why don't they put on gloves that, you know, Hollywood starlets wear, where they come up and they cover the whole entire arm?
These are hands, we have cuts and
Yeah.
and everything.
I generally am not walking into things and just banging my arm. And when I reach into my pocket, I generally am not reaching down to my ankle so that I'm constantly irritating this. But when I take my hands, you put them in your pockets, you grab things. These are the things that have little tiny cuts on them. That's the reason why you put gloves on. So intact skin is actually very beneficial. And there are things that are on there. So we have keratin. Okay, remember that top layer of your epithelium is that 30 layers of dead, keratinized, squamous epithelial cells. Keratin is a natural protector of underlying tissue. The skin doesn't really, it's not super acidic, but it does have a lower pH. Lower pHs tend to inhibit antimicrobial growth. This is one of the ones why, if you're at home and you want to disinfect something, vinegar, acetic acid. Very good killer of most things, okay, as long as there's appropriate exposure to it. We have sebum on our skin. Oils. The oils, again, are a way of protecting underlying tissue from antimicrobials, things that have the potential of getting in and doing potential damage. Now, we also have mucous membranes. Remember, mucous membranes are things that are exposed. They're inside our body, but they're exposed to the outside. Our eyes are mucous membranes. The nose is a mucous membrane. Mouth is a mucous membrane. Your anus is a mucous membrane. The vagina is a mucous membrane. The urethra is a mucous membrane. So these are all things that have access to the outside world. They are wet. Skin tends to be dry. Okay? But because it's wet, it doesn't provide the same level of protection. It's much easier to cut tissue on the inside of your mouth than it is on the outside of your skin, because it's wet and therefore it doesn't provide the same structure. But there are very important things that are present there. So just like we have on the skin, we have this acid. We see the acid probably in the biggest concentration besides the stomach in the vagina. This is one of the reasons why, so in the vagina, there is a very high level of glycogen. And when glycogen gets broken down, when it gets metabolized, it causes an increase in our hydrogen ions. And as we've talked about over and over and over again, just to continue putting this into your head, that means my pH is going to go down. And a low pH is very, very inhospitable to pathogens. This is also the reason why when you have females that become sexually active very young are at much higher risk for contracting sexually transmitted diseases, because they don't have that level of glycogen in their vagina. Therefore, it's not as acidic. Since it's not as acidic, much, much higher risk of contracting STDs. This is sometimes referred to as the acid mantle. So you're going to hear that a lot, both in the skin and in the body. When we talk about the pH in its regards to the immune system, it's referred to as the acid mantle, M-A-N-T-L-E. So I already talked about that acid that's in the stomach, but we also have proteins that will specifically, well, enzymes that'll digest proteins, but there are proteins that do play an immune response. But these enzymes have an ability of breaking down all proteins, even pathogens. So there are some that have the ability of escaping that. This is where you get a foodborne illness. So, we always think that the stomach is going to kill everything. Well, if you eat things that you probably shouldn't have eaten, a sushi roll from a gas station dispensary, it might not be the best place to get it. Saliva. Huge amounts of things called defensins, which are peptides that have antimicrobial activity. There is a chemical that is pretty much everywhere in every fluid, and we've talked about it already, but lysozyme. So saliva we see, and again we'll talk about this to a greater degree in the pathophysiology, but this is one of the reasons why what would be considered insertive oral intercourse, receiving oral intercourse, is not a way of contracting HIV. Okay, because the saliva has a great ability of deactivating the virus based off everything that's there. We have this layer. It's called, depending on how deep you go into it, but it's the gel and the sol layer. And we find it pretty much where we have any of our mucous membranes, but we see it specifically here in the respiratory system. Okay, this is like flypaper. It's mucus. Okay, I think your book is going to use the term mucin. So mucin is just this thick substance that when you add water to it becomes mucus. But it's very, very thick, and it sits along the wall. So if this is the wall, it's going to sit here. So as air comes in, if there's any pathogens in there, they could potentially stick to this gel layer. And then sitting underneath the gel layer are the cilia. And the cilia move in one direction, up. So as I've talked about in AMP1, this is one of those reasons why people that smoke cough when they wake up in the morning. It's because they've been having cigarettes all day long, and those cigarettes paralyze the cilia. So when they go to bed at night, unless they have a pretty severe addiction, the cilia then become unparalyzed, and they've been moving this mucus up to the top of their throat. So when you hear people go, and then they swallow it and you get all disgusted, you do that all day long. You might just not make the noise. You swallow a quart of snot a day. Okay? So you really should never be hungry. Now, this is just naturally going to move things up. It's called the mucociliary escalator. And again, the things that inhibit that, smoking is probably the primary thing. It's one of the reasons, again, why they have a higher incidence of respiratory tract infections, because they're not moving that material out. And it's wet, it's warm, and that's a great breeding ground for bacteria. So that's basically keeping everything out. That was your first line of defense. And think about it, they're the borders. That's why I like this particular thing in the Interactive Physio Suite, because they show the castle, and then they basically describe it as, let's prevent things from getting into the castle. That's your first line of defense. But occasionally, things get inside. So now we have our second line of defense. Now again, this is all non-specific. This is all innate, which means it doesn't matter who the bad guy is. Just matters that it's recognized as not self. And not self is then who we mount that attack against. And we're going to do it by a variety of things. The first one are cells. And the first group of cells are referred to as phagocytes. And again, phagocytes are just a general term for any cell that has the ability to undergo phagocytosis. So the big ones are macrophages. Remember, these are the big, giant, large ones that can eat and eat and eat and eat for days. They're in the same category as our monocytes. Remember, the monocytes were the football players at the buffet, where the neutrophils were the cheerleaders. They were just going to have the salad. Dendritic cells. Kupffer cells are the same thing as dendritic cells, except they're fixed. They don't get to go on vacation. They're just kind of stuck there. We see them mostly in the liver. By the way, these cells are all going to be in a very specific place. After our lecture yesterday, where do you suppose we're going to find them? What was the lecture on yesterday? In our lymphatic system. They're going to be based in the lymphatic tissue. Why? Because I'm going to be sucking things up from the tissue and things are going to be coming by. And remember that reticular fibers, they were like the hammock. So I've just basically got a cell that's like, there's one, get it. There's one, get it. Okay? So it's like when you watch the bears get the salmon. They know exactly where the salmon are going to be when they're coming back up. Because they're not going to sit there and try and hunt for them. And then we have our neutrophils. Okay? And neutrophils, again, were our white blood cells, our leukocytes, one type, that were usually the first to be active specifically in a bacterial infection. Now this process of phagocytosis we've never really talked about. Okay? And with phagocytosis, keep in mind that a cell has to have a boundary. Okay, so on the very first day of AMP1, we talk about what you have to have for life, and part of life is a boundary. There is a separation between me and the environment. If there wasn't, then I could have the rain come down, which it does in Oregon all the time, and I would just absorb it. And I'd walk around until summertime as the Pillsbury Doughboy. Now, a cell is the same way. It has to have a boundary. And anytime the cell membrane is impacted, damaged, pretty much the cell is going to die. This is, by the way, how antibiotics do their killing. They generally disrupt in some manner the ability of that cell, the bacterial cell, to have an intact wall. Okay? So I don't want to just bring anything into my cell. If I do that, I have the potential of damaging the membrane. Okay? So the first thing that's going to happen is we have to have a thing called adherence. So this cell actually has these receptors that can reach out into the extracellular fluid, which would be all the white stuff here. Everything you see here that's white is extracellular fluid, which is where this structure is. And adherence means I have to be able to grab that bad guy. And what happens is when I grab the bad guy, I'm going to pull it in, I'm going to circle my arms around, and I'm essentially going to pinch off part of the cell so that I'm really not bringing this stuff directly into the cell. I'm keeping it into what's referred to as a phagosome. So there is fluid from the outside, from the extracellular fluid inside the cell, but I still have an intact cellular membrane. So now, what you would see here inside this vesicle, the phagosome, all this kind of pink, I guess, for, I don't know what I'll call that, would be extracellular fluid. Now, occasionally, pathogens have an ability to not be grabbed onto. Think of a pig covered in oil that you're not going to be able to reach out and grab because it's going to be a slippery pig. Okay? So what the cell does is it places handles on the bad guy. So now I can grab onto the handles and have adherence and pull it in. Okay? Those handles are referred to as opsonins. Okay? O-P-S-O-N-I-N-S, opsonins. Right? I'm going to talk about opsonization in just a second. Opsonins are the handles. The placement of the handles is called opsonization. So this long word just means I'm placing the handles on the bad guy. What are the handles called? Opsonins. And that way, it facilitates the process of bringing these structures in. Now, once they come in, I'm going to take a thing called a lysosome, which is filled with some nasty acid, and it's going to fuse with this vesicle. Okay, and as with everything in anatomy, we're always going to have to change the name, so now it's called a phagolysosome. And all that acid, those nasty little structures, are going to come in here and essentially destroy what was phagocytized. And basically through transcytosis, in other words, I'm going from one part of the cell to the other, I then bring it to the other side. We go through a reverse process that we did to bring it in. And this vesicle now is able to fuse with the membrane, not opening the whole cell up to the outside. When it fuses, it opens it, they fuse here, and then all those particles basically just go out into the extracellular space. Hopefully in an inactive, non-pathogenic form. In other words, they're not going to cause harm to the person anymore. Now occasionally, either the pathogen has a high level, it's very virulent. Okay? The more virulent something is, when you hear that term, it means it has a greater chance of causing disease. It's worse. Okay? So Ebola is more virulent than a rhinovirus, which causes the common cold. Unless you are 109 years old or a premature infant and you have absolutely no immune system whatsoever, more than likely you're not going to die from the common cold. If you get Ebola, there's a good chance you're going to die. Okay? Now, sometimes this process doesn't kill. Okay? Doesn't destroy what was phagocytized. So they have what's referred to as a respiratory burst. The other term that you might see in literature is called the oxidative burst, because it utilizes oxygen. And it's going to make, and you don't have to memorize these by any stretch, but it's going to use superoxides, peroxides, bleach-like structures, and there's a couple different what are called cytokines. Cytokines we'll talk about more, but they're chemicals, proteins that they're like hormones, except they're specific to the immune system. So if I release a cytokine, I can change the activity of each of you if you're an immune cell, basically by making you differentiate into something else or increasing your activity. Okay? It's like spinach to Popeye. Now, these things have to be triggered, and when they do, it just increases their killing ability. Okay? Now, the other place that you can also have this is it can be released outside the cell. In other words, this can start to manufacture some of these chemicals, and they can release it. So if there's something that's too large, that can't undergo phagocytosis, we might be able to destroy it on the outside. So a lot of textbooks say that neutrophils are really the only ones that undergo a respiratory burst or oxidative burst. Other textbooks and authors will tell you that some of the other ones do, especially the eosinophils that break down worms. Because if a worm is too large to ingest, then you're probably not going to be able to get it in there. So if I can start destroying it on the outside with this oxidative burst and then make it into smaller particles, then it can be ingested by other macrophages. Any questions on that part? Okay, so right now we're talking about cells. These are cells of the nonspecific system. These are the second line of defense. So again, when you go back to the thing, these are everything in this box right here is the second line of defense. So far we're just talking about the top two things, which are cells that are part of it. And again, that's how I would think of it. So I have first line of defense, mucous membrane, skin, how does it keep things out? Second line of defense, I'm going to break it down. I've got cells that are part of my second line of defense. I have processes, the inflammatory process, complement, fever. That's how I would think of it, because again, it puts everything in its appropriate part of the play. So it makes it easier to understand. So now we have a special type of lymphocyte, and it's referred to as a natural killer cell. Now we're going to talk about a cell that's similar to this when we get in the adaptive system, called a cytotoxic T cell. Very, very similar. The difference, this doesn't care about this part. Natural killer cells only care about not self. Now, essentially, when they find a cell that's not self, so this could be a virus, could be a bacteria, could be a cancer cell. Cancer cells actually have a not self on there. Our body just doesn't always do a good job about killing them appropriately. They take the cell, they bind to it, okay, and then they stick in these things called perforins. So what it's going to look like, and I'm going to go all the way to the end because our cytotoxic T cells are going to kill exactly the same way. So the perforins form the pore. A pore, P-O-R-E. So remember, cells have to have an intact membrane. Whenever their membrane is destroyed, this cell is destroyed. So in and of itself, just the fact that I'm putting these perforins there, that's going to do damage. But I'm also going to throw these things called granzymes in. And granzymes are going to cause the cell to undergo what's called apoptosis or apoptosis. And it is a potato. So you might have somebody go, that's not how it's pronounced. It is pronounced. So anytime you have the P in front of a T, a lot of times the P is silent. So there's a thing called ptosis, which is like a drooping of an eyelid, drooping of a foot. You don't pronounce the P. So here, it could be the exact same way. Apoptosis or apoptosis. And it's basically cell suicide. So this, it's like the opposite of Dr. Phil. So these things are going to come in here and basically tell this cell you need to kill yourself. It lowers its self-esteem, it doesn't like itself, takes away the antidepressants. It actually does bind to a FAS receptor, and the FAS receptor is what causes the process to work. So you'll see this again when I talk about cytotoxic T cells, because this is the same thing cytotoxic T cells do. They're just part of a different system. They're part of the adaptive system. Any questions on it? So again, that's where you're going to see the not self-receptor. So this is the flagpole. This is what's called an MHC class 1, and it could be a class 2, but we'll make that differentiation when we get there. But this is the flag. So that it knows, oh, this is not self, I need to kill it. And again, when we get a little farther, we'll talk about just exactly how that flag gets put there. Okay? So those are the cells that we're going to be seeing in the adaptive system. Or the innate system, the non-specific system. But now we're going to talk about some processes. So the biggest one that most people have heard about, and most people have probably experienced to some degree, is the inflammatory response. And I will tell you as I go through here, those of you who are going to work specifically in critical care units, you're going to see that sometimes the inflammatory response is not beneficial. There are times we actually want to stop the inflammatory response because it's a cascade effect. And it's all these things are being released that are essentially trying to help the body that are actually killing the person. So we stop that process from occurring. Okay? Why do I have it? 4 primary things. I want to keep this, whatever is occurring, okay, an infectious process, a trauma, so injury, I want to keep it local. So in other words, if I do something to my thumb, I'm going to see my thumb get red, swell up, be warm, possibly have some pain. The whole purpose of that process is to keep this from causing a systemic infection. Okay? So we want to prevent the spread of whatever is causing this. I want to tell the rest of the immune system, hey, heads up. we've got some sort of activity going on, you're going to need to be called up here, because even though our innate system is the first one to be activated, more than likely the adaptive system is going to come in and kind of run the show. Okay? Because it's specific. It's like, oh, we've got a battle. Well, who are we battling? Oh, we're battling bad guy A. Oh, not bad guy A again. So then they have to ramp up, and then they come in to fight bad guy A. Not every bad guy. So it's a little bit more of a surgical strike as opposed to this big battle. We're going to get rid of the battle, because that's what this is going to be. The good guys are going to come in and battle the bad guys, and there's going to be death, there's going to be pus, there's going to be cellular debris. Someone's got to pick that up. And that's what the inflammatory process does. And then the last one should make some sense. We're going to get ready to repair what was damaged. So our growth factors are going to come in. We're going to make more cells. We're going to make more collagen. We're going to make more elastic fibers, more smooth muscle cells, and we're going to build everything back up. Now, whenever you see the term cardinal, okay, it usually means the more common. So the cardinal signs are basically, hey, if I have an inflammatory process, more than likely these are the signs that I'm going to be looking for. This is one of the reasons why if you have something that's going on, the person who's evaluating you is going to look at the color. Well, it doesn't seem really red. They're going to feel it. It doesn't feel real hot. You probably don't have an inflammatory process. But if it's super red and it's very hot, those are two little signs that you want to ding off that say, hey, maybe we're having an inflammatory response. I can have some swelling. So you twist your ankle. Or you have a cut on your foot. And suddenly your foot's nice and big, it's red, it's hot. So again, when you have surgery, they come in, they look at the surgical wound. They want to make sure that there isn't something that's starting to spread along the process. Pain. Pain's another big sign for your inflammatory response. Okay? Not everybody has all of these, but again, these are the cardinal signs. And the last one, not every author puts this last one in there. Okay? Your author does. It's called impairment. In other words, I can't use that joint, I can't use that part of the body. More than likely because of the swelling, because of the pain. It's a protective mechanism. It hurts when I do this. Don't do that. Okay? Now, and we're going to look at this from the steps, and then I'm going to show you this big giant picture here. It's a little intimidating, but it basically elicits the whole entire response. So, the first step in this process is going to be the activation. Okay? Now, macrophages have receptors on them. And one of these receptors is called a toll-like receptor. And when they sense that there is some sort of an inflammatory process going on, usually because of other cytokines, other chemicals that are present, that's what causes the bell to be rung, then the cytokines, extra cytokines, are going to get released. Okay? So we're going to see histamine. So if you've ever seen anybody that has an allergic response, it's not uncommon for them to swell up. Why are they swelling up? Because of histamine. Histamine is causing one of the first signs, or one of the first responses, which is vasodilation. So we just covered our vascular chapter. What do you suppose happens to a tissue? So again, let's take a look and say that this, this desk is a blood vessel, and there's tissue on the other side, so the blood's coming towards me. What happens if I cause a vasodilation in that blood vessel?
More blood.
More blood comes to the area. What color is blood?
Red.
Huh. It's one of your cardinal signs. What temperature is blood compared to the rest of the body?
Warmer.
It's warmer. Huh. Maybe that's why we have an increase in amount of heat. So these two things are because we have an increased amount of blood flow to the injured area. Why did I have an increased amount of blood flow to the injured area? Because we have histamine, kinins, prostaglandins, and I'm going to kind of hold off here because complement really doesn't play a role from that standpoint. Complement is another process that we'll talk about. But all of those things causes a vasodilation. Now, they also cause increased permeability in the vascular space. So as fluid now is coming from that end of the blood vessel to the tissue over here, what would increased permeability mean?
You can get into the tissues better.
Yeah. So if you just think about all along this way, we have all of these cells, the endothelial cells. The spaces between the endothelial cells get bigger. My intercellular clefts are now larger, which means the fluid on the inside of the blood vessel can leak out. So if fluid leaks out into the tissue, what does that do to the size of the tissue?
Swelling.
Yeah, what's it called when fluid leaks out in the tissue and stays there? Edema. Edema is swelling. Now, please make sure that you understand this. This is one of the reasons why I made a point yesterday of talking about edema and saying lymphedema was edema that was caused by blocked lymph nodes. Edema does not mean you're having an inflammatory response. Edema just means there's excess tissue there. The inflammatory response usually means that I've got all of these things occurring. So when you have increased amount of swelling because it's an inflammatory response, that's not lymphedema. We still call it edema because it's swelling of the tissues. Now, I have nerve endings that are in this area. So an increased amount of fluid in the area is going to push down on those nerve endings and cause pain. So increased capillary permeability. So here's my arterioles dilating. It's called hyperemia. Hyper meaning a lot, emia meaning blood. It just means that I have an increase in blood flow. That causes my heat and my redness. The increase in the permeability, so things can leak out. I have swelling, so not the stuff that comes out is beneficial. This is going to be some of the stuff that is our clotting factors, growth factors, things like that. And it's going to cause swelling, which will cause my pain. Now, the other reason that you might have pain is because of this thing right here. Kinins have a tendency to increase your sensitivity to pain. So the more kinins are released, normally you might go, oh, well, you have to hit me with a hammer before I feel pain. Now, just touching it, I feel pain because I have an increased sensitivity to pain. Why? Because when you have pain, it's your body's way of saying, you have pain, stop doing whatever it is that you're doing, which leads to the impairment. Now, we need to start this inflammatory process, which is what we did with the vasodilation and the increased permeability, but that's not the only step. I now need to have my cells that we just got done talking about, my macrophages, my neutrophils. So I need to activate my phagocytes. So remember, leukocytosis, I'm going to have an increase in the amount of white blood cells, because neutrophils make up the largest group of our white blood cells. And they're going to start rolling along. Now, them rolling along is called margination. Because if I'm driving and I don't really have my GPS and I left my phone at home, how do I know what exit to get off where the injury is?
Use your eyes.
I could use my eyes. These don't have eyes. They don't have a GPS.
Signal being sent.
I don't think they have a GPS, but it could be the voices I hear. It's like, oh, get off over in the radar.
It's a signal being sent from the affected area.
It is a signal being sent, but it's not being sent away. What happens is we have these things called cellular adhesion molecules, okay, CAMs. Hopefully you remember at least the term from AMP1. CAMs are things that essentially help things stick together. Cellular adhesion, stickiness, molecules, okay? And the two big ones are called selectins and integrins. So endothelial cells in the area of injury will sprout selected. The neutrophils will sprout integrins. And as they start rolling and getting closer, the integrins from the neutrophils and the selectins from the endothelial cells match up. Hey, this is where you're getting off. This is the exit. Since this is the exit, it now has the ability. Remember, there's one thing that there's a couple things, but one specific thing white blood cells were allowed to do that red blood cells were not allowed to do. Which is what? Leave the blood vessel. And what's that called? Diapedesis. So margination is I'm on the move. I'm going to the site of the injury. How do I know where to get off? Cellular adhesion molecules. Once I sneak out, the ability of sneaking out is called diapedesis. So now I've gotten off on the correct ramp. So now I've snuck out of my car. So now I'm standing out here in the tissue. How do I know where to go from here? Chemotag. So this battle that's been going on is going to release chemicals. It's going to release cellular debris. These are breadcrumbs. Okay? And these cells will follow the chemotaxins. Now this is going to be very important. So this says chemotaxis. Okay? That's the process of following chemotaxins. Chemotaxins are the breadcrumbs, so that the phagocytes are able to then reach the site of the injury or the infection. And again, I can have this with both. I can twist my ankle and have an inflammatory response. I can walk along a path barefooted and step on something and get an infection and have an inflammatory response. They're exactly the same. Now, we're going to start cleaning up the area. We're going to wall it off. We're going to have this big giant battle. And all of this fluid from inside the cells, both the cells that are good cells that died in the battle and our pathogenic cells. So we're going to end up with pus. So that's all pus is generally, is this fluid material that contains all of the cellular debris. And then we start walling the area off. I start building up things. I start repairing it. And occasionally, we do such a good job that the infectious process is not done. But I build up a wall to prevent it from going farther. And when that happens, it's called an abscess. So an abscess is basically, we built a wall around the battle and the battle isn't done. But it starts to expand and usually expands both up and down. Some bacteria are able to do this on their own. They kind of wall themselves off. So they prevent themselves from being destroyed. And then they go and live in different parts of the body. So tuberculosis, it can actually live in any part of the body, but we have its greatest effect in the lung. So it basically just goes to the lungs and it sits there and it wraps itself up in this little granuloma that can be seen on an X-ray. And it waits, and it waits, and it waits. And when your immune system goes down, it gets freed up, and the TB bacteria then causes you to get tuberculosis. Now, from this standpoint, what you can have is probably one of the nastier things that you're ever going to encounter in the healthcare system, which is so it's a little hard to see if I can do this. So this is in a foreign country. We would not do it this way, and I'm not saying every foreign country does it this way, but so what he did was he made a little mark. So you're going to kind of see that. And essentially there's just this big giant pus-filled sac that still has an infectious process going on. And if it's not removed, it has a tendency more often than not to go down. So it's starting to erode. So if I had an abscess in my leg, it would start to erode everything down here and not come out the skin. Well, what's down there? Muscle, bone. So it's important that these get taken out. So he'll start to apply pressure. And it's basically a zit. It's just a really super infectious zit that can kill you.
So is it staph?
That's a what?
Staph.
It could be anything. This is just an abscess. The infectious process,
good one.
infectious thing could be anything. And for some reason they put this in a bowl and stir it up. I'm not quite sure why.
You're gonna eat it.
I mean, not just I'm going to put it in there, I'm going to stir it up like it's going to be a sauce on something. Now, the other thing that has to be done here is we have to now go in and we have to remove the dead tissue. So the healthcare provider is going to look to find what they feel is tissue that's not going to be able to survive. We also do it differently. He's going to start pulling on this tissue. We would use a scalpel and scissors, but he's going to go in and just start pulling.
Gloves.
Why are they stirring the pus? I don't know. I mean, that's just one of the questions that should pop up in your head. So the tissue is going to get removed because we don't want it to be part of the process. And then what's going to happen is we're going to take a gauze that's impregnated with the bacteria, and it's going to get shoved down in. And we leave it open. So essentially, we're allowing it to heal from the inside out this time. Okay? So the top is always going to be left open, and then what will happen is the healthcare provider will then go in every so often, pull that gauze out, they look at the thing, they measure the wound to see if it's healing, and then they'll put more in. The smell of these things, probably some of the most horrific things that you will smell. You're going to have to play this little, kind of having an indoor, you have an inside voice and an outside voice. So you also have to have an inside face and an outside face. And I think I'll tell two different stories, but one of them, when somebody's sitting there and they've got this, and a lot of times this is from some lower socioeconomic people that are IV drug users. I was teaching a pediatric advanced life support class in Longview, and apparently they had the same kind of meth problem that we had along the I-5 corridor. And I wasn't paying attention. They were ER staff, and they talked about somebody coming in with meth spider bites. And I was like, so are these spiders that got into meth and they're just a lot more aggressive? And you can just see them just like throwing the thing, reeling them in. So a lot of times people come in and they'll say that they're spider bites, and really they're just because they pop and they get abscesses and those types of things, and they're specifically from IV drug use, which can lead to abscesses. But they feel bad enough. And so when the stuff starts to come out, you can't be going, because that really doesn't make them feel any better. And you can't make noises about, about the smell and things like that. So you just practice your inside voice and your inside face going, dear God, shoot me now. And just as a separate note from along the same path, but because again, most of you are going to be working in the healthcare field, and it is important, not just for things like abscesses. I had this kid who came in Sunday morning. I looked at the intake form, and it said plastic object stuck in rectum, and you're like, how's it going? Pretty effed up night. And what was so effed up about it? So he goes in and talked about taking a shaving can, and his girlfriend was not there, and he put it up his butt, and it was gel for those men who shave, not a Colgate, because Colgate's this big, gel's over that big. Not that either one would be pleasant, but imagine the gel. Well, he put it in cap side first. So when he pulled the shaving can out, the cap stayed in. So I said, so what did you do then? Well, I had another beer. Took a shower, and he goes, and I called 911. I said, you came here by ambulance? He goes, well, I wasn't going to ride my bike down here. But I mean, he felt stupid enough as it was going through the process, because you then have to medicate him so that they can have the procedure tolerated, so that the rectum can be dilated and we can pull the object out. You have to be able to just have that, not, are you a fool? Those aren't the types of things. So again,
start practicing your indoor voice and your inside voice and your inside face so that you don't make people feel worse than they already are, because they just don't want to, kind of stuff. So any questions on that component? Because we're not done with the innate system yet. That's just the first part of it. We're going to still talk about complement and fever and those types of things. Any questions? Why don't we take a quick 5-minute break? Try and be back by about 5 after, and we'll... So again, we're done with the cells. We talked about one of the processes, but there's a second type of character, so to speak, in this place. It's not a cell. They're protein. Okay? And probably one of the biggest ones is going to be interferon. Okay? Now your book's going to go into the different classes of interferons that are there. It's not super important that you know them. I do want you to be aware that there are different classes. Okay? So you have the gammas, alphas, and betas, but you don't have to tell me what they do. I don't even care so much that you're able to tell me gamma, alpha, and beta. But they do exist in different classes. They have two primary jobs. Okay? The first one is when I have a cell that gets infected. Okay? So here's a normal body cell that's been infected by a virus. Okay? And interferons tend to be active with viruses. That's their main gig, and I'll tell you why. When we think of a virus, so the different types of pathogens that you're going to see, three of them you've probably heard about, but you've got bacteria, you've got viruses, you've got fungi, you've got protozoans, and you've got these multicellular things, which would be your worms, okay? And they kind of go up in size. Viruses are probably the smallest amount, or the smallest size that we're going to see, because they're not real cells. What they are is essentially a strand of DNA or a strand of RNA. So when we talk about HIV, HIV is an RNA virus, so it has a strand of RNA in it, and that'll play a big role when we talk about the pathophysiology, about how it affects it. They're not able to do anything really, unless they infect a cell, because they can't replicate on their own. So they have this special strand of DNA or RNA that's wrapped in a protein coat. Okay? So what they do is they gain access to a healthy cell. Okay? So that's basically like breaking into this building, going into the office, and taking command of the office and telling Vaughn to go over to the copy machine, and I want you to make these copies. Okay? So using the physiologic process, they will insert either the DNA strand into the host DNA, because remember that's what's inside of it. If it's an RNA, the RNA has to become DNA, and then it gets inserted in here. And then it tells them to say, hey, now start copying. I want you to print this and print this and print this. And so just those particular genes of the virus that make up the DNA or the RNA and the coat. Because I have to be able to wrap that DNA or RNA up into a coat. And that's its function. Okay? Now, when that occurs, when it gets infected, we release interferon. And what this infected cell does when it releases interferon is allows for the interferon to come to a cell that hasn't been infected and say, what I want you to do, it doesn't always stop the RNA or the virus from getting inside the cell, but what it does is it prevents it from getting into the copy machine. So it can't insert the DNA. So that's one of the tasks of interferon. The second task is it's going to increase the activity of macrophages and natural killer cells. So in that instance, it works similar to a cytokine, but it's not a cytokine. It's protein. Well, interferons can, depending on the author, can be placed into cytokines. Cytokines, you're going to start seeing it as kind of a big umbrella term for different chemicals that are present there. Any questions on interferon? So two more processes that are going to occur with our proteins. The second one is going to be called complement. Complement's about 20 different proteins. And they basically stay inactive in the body. They just float around until they're activated by the toll-like receptors for the inflammatory response. So it's a cascade effect. Okay? Now, there are actually 3 pathways. So this is going to look very similar to that the hemostasis pathway, blood clotting, where we all came down to that common, the factor 10, and then we activated our prothrombin activator, which activated prothrombin, thrombin, fibrin, and then we had our clot. Here, this is the common pathway, C3. Now, I will not be asking you to tell me all of the proteins in complement. You should know there are about 20 inactive proteins. And when activated, they all come together to form this process. Now, there are essentially 3 ways for C3 to be activated. The first one comes from the adaptive system. And we have what's referred to as an antibody-antigen complex, which is right here. So these antibodies that we talked about a little bit in hematology, which we're going to spend a lot of time talking about on Monday, are going to bind with the bad guy. And it's that binding then is going to cause an immediate activation of C3. I'm not talking about what C3 does just yet. We're getting to C3. These are the 3 different pathways of doing that. The second one is some of these bad guys, pathogens, have a coat. And that coat is covered with carbohydrates, sugars. And it is the pattern of those sugars that is recognized by cells that then turn around and activate C3. Bless you.
Thank you.
Now the last one's a little bit more difficult to understand, which is essentially there isn't anything that inhibits it. So I don't have a flagpole that says one of these. It doesn't say self, it doesn't say not self. So if it said self, it would inhibit the process. If it said not self, it would activate the process. It doesn't have the flagpole. And because it doesn't have the flagpole, it's kind of a spontaneous activation of C3. So what happens when C3 is activated? This is the part that you do have to know. And again, I'm not going to ask you to give me all of these different things. I just want you to know 3 different ways of activating C3. Once C3 is activated, the first thing we're going to do is I'm going to start making some handles and putting them on these things. Why? So that I can adhere and pull them in. It's going to increase phagocytosis. So the first thing that occurs is opsonization. The second thing that's going to occur is it's going to increase everything that we talked about in the above steps in the inflammatory process. Vasodilation, increased permeability, phagocyte activity. It speeds it all up. And then the last one, we form what's referred to as a membrane attack complex. This looks just like that thing that the perforins do with the natural killer cells, or the natural killer cells of the perforins, and the same thing that cytotoxic T cells do. But here, instead of throwing anything in, like the granzymes, I'm just making a pore. What does that do? Opens the membrane up. What happens to a cell when the membrane is disrupted? Dies. And I can't see if you give it, it kind of looks like there's smoke. There's no smoke that comes out there, but it certainly drives the point home that something bad's happening. That's referred to as lysis. Lysis is the breaking down of. So this membrane attack complex is going to cause lysis, and the cell will be destroyed. Now, there's a diagram from another textbook, The Clinical Physiology Made Ridiculously Simple. This is one of the reasons I like the textbook, because it kind of drives the point home. What does complement do? It pours oil on the situation. Opsonization, inflammation, and lysis. So here's my neutrophil or my macrophage, a phagocyte, correct? Here's a pathogen. What's it doing with the pathogen?
Here.
I'll put a handle on it. He's not very happy either. And then he's going to get eaten. inflammatory process. What's it called when a little white blood cell is able to squeeze out of the blood vessel into the tissue? Diapedesis. It's happening right here. So the histamine gets released. It's causing an increase in permeability, and I have diapedesis. And then the last one, we're going to disrupt that cell membrane. So here's the pathogen. You can see a cell membrane is activated, and he will die. So again, just another, it's just a picture way of remembering everything I just talked about. Complement, pores, oil, over the situation. Opsonization, inflammation, lysis. Okay, again, 20 inactive proteins along the way that will essentially cause handles, inflammation, breaking open that cell. Again, all non-specific, meaning I don't care who the bad guy is. So you're going to see all the different letters and so forth here, and again, don't get lost in them. You should know. And I think the only thing missing here is the fact that there is a third one, the lecithin pathway, so you should probably add that on there and be able to describe them. But the only one I really care that you know is that they all lead to C3, and once you have activation of C3, we have those three responses. Now, last part of the non-specific system is fever. Now, your body, we have the hypothalamus, and the hypothalamus essentially is the thermostat of the body, regulates your body temperature. And during this infectious process, we have the release of a thing called a pyrogen. Now, every book's a little different. Some of them implicate prostaglandins and say the prostaglandins are the pyrogen. Other textbooks will tell you the prostaglandin or the pyrogens cause prostaglandins to be released. Pyrogen is fine. Okay? And what pyrogens are going to do is they're going to go over to the hypothalamus in the brain, and they're going to reset the thermostat. So instead of being 98.6, we're going to say we want it to be 102 degrees Fahrenheit. So the body then says, just like what would happen in your house. If I was in my house right now and I went from, if I took it from 72 degrees and I put it up to 80, and it's not 72 degrees in my house, or it's not 80 degrees in my house, it's only 72, what system is going to turn on? The heater. I got to heat the house up. Why? Because that's what the thermostat says. I want to be at 80. So when I take my pyrogens and I jack my thermostat up to 102 degrees, now my body has to get hot. It has to develop a fever. How does it do that? Again, we're talking about how the body does it, not I'm going to go put on a blanket, I'm going to put on a sweater, I'm going to put on some long johns. It's the body itself is going to do this.
Shivering,
Why would shivering do it?
muscle contraction, heats up.
Friction between muscles.
Right, so muscles are 40% efficient. So whatever I don't use to move my body is going to be given off as heat. This is the reason why when you're, again, watching a duck football game on a Thursday night at 8 o'clock, and you didn't take all the appropriate stuff and you start to shiver. You're shivering to increase. So you're not shivering because you're cold. You're cold and your body shivers to make you less cold. So the shivering increases your body temperature. Okay? Liver is going to help with that process. Metabolic processes are going to help with that process. But shivering is probably the biggest thing that's going to drive that up. So our body temperature goes up and we have fever. Okay? Now, why do I have fever? A couple reasons. First one, that high temperature has a tendency to inhibit the activity of the pathogen. So just by the fact that the body is hotter, there's a potential that it's going to inhibit the activity. The second thing that occurs with fever is that we take different chemicals, chemicals from your periodic table, but chemicals that are in your body, magnesium and zinc, and we hide them away. We sequester them. And these are things that are necessary for pathogenic reproduction. So in other words, I hide their fuel source. So if I hide their fuel source, then they can't reproduce. If they can't reproduce, then it gives my body a greater chance of fighting the bad guys. Because now they're not going to be plentiful, and they're going to be weak. Once the battle's done, now this can happen, by the way, over and over and over again. Okay, there's different terms, and I don't care that you learn, but one of the terms is stadium, there's effervescence. The stadium is a part that has where it's up high, but it can go up and down and up and down and up and down. In other words, you can have a fever that goes up for 2 or 3 days and then goes down, and it can come back depending on the pathogen that's there and depending on your immune system. So it's not just a one-shot thing, okay? But if we describe it as a one-shot thing, when the pyrogens go down, then this gets reset back. So now I'm going to then bring my temperature back down. So I'm going to take my 102 and I'm going to set my thermostat now at 98.6. Well, if I'm at 102 and my new temperature I want to be at is 98.6, the air conditioner is going to come on. So how do I cool my body off? And again, we're not talking about taking your clothes off. That's a thinking process. What does your body do?
You sweat.
It sweats. Because as it sweats, it brings the heat to the surface, and then the air comes by through evaporation. It's a great way to get rid of heat. So here we're going to shiver. Over here we're going to sweat. That's why every now and then when you watch really old movies and it shows somebody and they're just sweating like a pig and someone says their fever has broken, just means that you're kind of on this side now, probably getting better because the pyrogens are being decreased from that standpoint. Any questions on that? Yes, did you have a question? Yeah. Okay. Yes, sir.
Does the thermostat in the hypothalamus change explain why you can feel cold and feel hot when your temperature is opposite? Like you feel cold when you have a temperature and then feel hot when your temperature
Right, but the reason why you feel cold is because your body's saying you need to be at a higher temperature,
Yeah.
and you're not there yet.
Yeah.
So yeah, that's what happens. So you'll hear a lot of people, you know, when they're shivering, they feel cold until the shivering starts to raise their body temperature. Any questions? So when you look at the breakdown of this, okay, and again, I'm going to kind of keep going back to this. We've covered these two boxes right here. That's the innate system, the non-specific system. And I would make sure that you have it down because you're not going to have that much time to really start putting things together. Because on Monday, I'm going to be going over the adaptive system. What I don't cover on Monday, I'll finish up on Tuesday, and then we cover pathophysiology. And then, you know, Wednesday's a free day, so you're trying to put all that knowledge in your head. So I would try and put a chunk of it in your head this weekend. Okay? But, again, first line of defense, second line of defense. When you look at the internal, the second line of defense, cells, processes, proteins, and then fever. Any questions? All right, have a email me.